very special production here in the Rural Impact Podcast Studio. Today, we are elated to present Exploring the Power of Collaboration, Pathways to Transformative Rural Health Partnerships, made possible by the National Association of Community Health Centers. I'm Michelle Rathman, and I will be your host and moderator, and we can't wait to have you hear from all of our guest panelists today. But before we begin, let's cover the learning objectives for today's discussion. Because by the end of this learning event, we're going to do our very best to ensure that you can describe the value of strategic partnerships between health centers and hospitals in rural areas, identify key considerations for developing and sustaining collaborative rural health partnerships, explore case study examples that demonstrate practical approaches to partnership design, implementation, and coordination, and recognize opportunities to strengthen access, operational sustainability, and service delivery through cross-sector collaboration. Now, let me tell you a little bit about our lineup. First up, you will meet Gina Capra, Chief Education Officer at the National Association of Community Health Centers. Next, you'll meet our first two collaborators from Berlin, New Hampshire, Michael Peterson, President and CEO of Androscoggin Valley Hospital and North Country Healthcare, and Ken Gordon, CEO of Coos County Family Health Services. Next, we welcome Jim Pettinato, CEO of Wayne Memorial Hospital, and Terry Lacey, CEO of Wayne Memorial Community Health Centers, joining us from Honesdale, Pennsylvania. And then we welcome Kurt Walbillig, CEO of Cole Country Community Health Center and Sakakawea Medical Center, as well as Chastity Dolbeck, Director of Patient Care and Innovation, also at Cole Country Community Health Center, coming to us from Beulah, North Dakota. Once again, we're so glad that all of you in the studio are with us, as well as for those of you joining us for our live stream on YouTube. We're so glad that you're here. We're ready to get started. We know you are too, so let's go. Hello, one and all, to all 400 or so of you amazing rural health champions. As you heard in the pre-recorded introduction, I'm Michelle Rathman, a rural health and community engagement strategist. And some days I am the host and creator of the Rural Impact Podcast and our virtual event platform, which is where you are here today, that elevates and connects the dots between policy and rural quality of life. And as you will soon hear, we explore community connections that create and support essential services that help support rural people and help them and their communities thrive. So before we get started, I just want to give you a few housekeeping notes. We've got a really packed power hour for you. Not only are we live in our studio audience, but you may remember only 100 or so people could get in, but you are also watching us out on YouTube. So we are so grateful for that. And this entire session is being recorded for replay so that in case some of those that you want to share with your network couldn't join us, that you'll be able to share that link with them later on. And also, I want to remind you of this right now and later, be on the lookout for a survey link because your perspectives on these matters do make a difference. And I know that our who made this possible, the National Association of Community Health Centers, really wants to hear your feedback from from this particular event. So because we are coming at you from a lot of different locations, some of us more rural than others. One thing to note, if someone drops out, don't worry, they'll be back. Everyone's being recorded separately. And so we just invite you to stay with us. Don't go anywhere because the conversation will continue. So with that said, I think it's really important. Again, we got a packed hour for me to give you some context as to even why, always asking the question why we're doing this event. And so with that, I want to make sure that I bring into the stage with me to the forefront, Gina Capra, because she really is the reason why we are here today. She might disagree, but Gina, why don't you come on and join us?
Michelle, thank you so much for having me. And hello, everyone. Really appreciate everyone's time and attention today. We have folks from all across the country, all time zones. And Michelle, you are also one of the reasons why today is happening. And I remember fondly our conversation when this was just an idea several years ago.
That's exactly right, Gina, why I want to have it. So just from a really quick background, because I know you all want to hear these case studies, but many years ago, I want to say it was before the pandemic, I can't remember really, but Gina and I met. She was gracious enough to meet me at a hotel. I was in DC for a policy conference. And I asked if we could sit down and have a conversation, maybe 20 minutes or so. We ended up talking for almost 3 hours. And the reason why we had this conversation is because I work with rural hospitals around the country, and in my former life worked with community health centers, FQHCs as they're known, in urban settings. And I really believe that for us to really take care of the rural communities that we all serve, that collaboration really is the key. And true collaboration does transform. And I know that rural health transformation is having a moment, but I'll tell you, it's been a movement for many years. And I asked Gina if we would be potentially interested in finding some case studies to show other folks the power of collaboration. So let's start there. Tell us why the National Association of Community Health Centers has taken such an interest in this topic.
Yeah, thanks, Michelle. And the National Association of Community Health Center is so proud to serve as an advocacy and a training organization for health centers across the country, of which there are over 1,580. But 40% of those health centers are rural serving health center organizations. And those 40% of health centers have 6,714 sites across the country in rural America, responsible for serving about 1 in 5 rural residents. And so that's no small number. That's amazing access and service. And so NAC was interested in, number one, learning how our rural community health centers formed partnerships with other social service and healthcare service delivery organizations. And then second, to understand the key components that made those partnerships successful. And then finally, we hoped if we could find those examples and document them, that we could raise awareness about these success stories as not only inspiration, but frankly, and more importantly, as practical peer guidance to others across the country. We know that organizations are in various phases and stages of relationship and partnership building. And so we wanted to hear from those success stories about their journeys. HRSA's Bureau of Primary Healthcare provides NAC with a training and technical assistance grant that allowed us to really spend time and energy and find these stories and capture them. And I give credit to our partner duos that we're going to hear from in a short while. So, Michelle, it's just so important. If 1 in 5 rural Americans are being served by community health centers, that's not happening because they're operating in a silo as their community health center. They're really looking to improve larger quality of life with partners.
Yeah, absolutely. And so just real quick, there are case studies. I had the privilege of writing these case studies last year. They are still under review. And I promise you, everyone who's registered for this will get them as soon as they're released. But as I interviewed everybody and as I did the writing and I've done the research and I've seen firsthand kind of the common thread over all of these case studies that we're going to be talking about and the leaders you're going to meet today is strategic engagement. And I live and die by the word strategic because I think that's so important. Relationships are one thing, but these are really strategic. And so I know it's very much a focus of your work as well, Gina. So before we bring in our first collaborators, tell us more about kind of the specific purpose around, your curiosity between health centers, rural health clinics, and rural hospitals and critical access hospitals, why you feel it's so important for them to kind of really focus in on this model because as I say, this is the year of building our bench, and we've had this conversation. Mm-hmm. No one organization can do it alone, especially with the very realistic challenges that we're facing. So let's talk a little bit about strategic engagement and your perspective there.
Yeah, thanks, Michelle. When you and I first talked about this idea, strategic engagement to me at that time was more about, well, what are the partnership models and what are the leadership characteristics necessary to form and evolve and nurture that? But in the last year, I think we have some much more forceful, practical issues at hand that require true strategic engagement. And so I'm thinking about the potential increase in uninsured patients across rural America. When we think about the impact of HR 1, we think about the interim final rule was just released on Medicaid requirements. We think about the ACA subsidies and the health insurance marketplace and starting to see that increase of uninsured Americans arriving for services. And then secondly, Michelle, a couple of years ago, health IT, while it was a thing, we didn't quite yet know about AI's potential. And now, when I think about the potential of reduced administrative burden and innovative staffing models, all within safe parameters, that's another piece that's going to require strategic engagement and collaboration on how are we safely utilizing and integrating AI into our service delivery landscape. And then finally, just the steady need for services. The health and wellness of rural America requires that continued attention. And so I think for these very pressing and real matters, strategic engagement is, as you always say, critical to rural communities thriving, not just surviving. And I would also say, why can't rural be leading in that space with the solutions that are on offer and modeling the engagement and partnership that we'll soon hear about? I think in a non-rural setting, sometimes it might be easier to go it alone. But in rural America, as we'll hear shortly, that collective impact, that force multiplication that happens when partners come together around shared goals and common aspiration is really where it's at. So I am so excited to hear from our panelists today because they are making a difference.
Well, that's a perfect segue because I really do believe that rural can and does lead the way. I mean, there is no other place than rural. That's why I'm smiling from ear to ear to show us really I think the power of rural is the power of collaboration. So Gina, thank you so much. You are so important to this conversation. We're just going to put you back in the green room while I introduce our first case studies. And they were the first two that responded when I say put my fishing pole out there and these different listservs looking for case studies. So with that, I am so excited to have you welcome to this particular segment of the program, Ken Gordon, Coos County Family Health and Medical Centers, and also Michael Peterson, Androscoggin Valley Hospital. And if I mispronounce anyone's names, please forgive me. I'll ask for forgiveness later. Michael and Ken, thank you so much for joining us.
Thank you, Michelle.
Michelle, great to be with you.
It's great to have you here. So listen, you're the whole reason why we're here, your stories. And so let's start off by having each of you give us a bit of a snapshot of where you are, because, you absolutely defined what it means to be rural. And I want folks to understand kind of where you are together in proximity to the rest of us.
Well, Michelle, we operate in Coos County, New Hampshire, which is the northernmost county of New Hampshire. It's also the largest geographic county in the state. Coos County Family Health Services operate as an FQHC. It operates 5 primary care sites, 2 dental clinics, and offers behavioral health services, substance abuse services, and we also provide services for victims of domestic violence and sexual assault.
And Michael, you tell us about your organization.
Sure. Thank you, Michelle. Androscoggin Valley Hospital is part of the North Country Healthcare family of critical access hospitals. We're the largest of the 3 critical access hospitals that serve all of Coos County, as well as Northern Grafton and Carroll counties, which is basically the top third geographically of the state of New Hampshire. We are a 25-bed critical access hospital and we're primarily the secondary treatment service in the county, meaning we have the only intensive care beds. We have most of the specialty services for the entire region, and roughly 450 employees serving a population of about 12,000 in our primary service area and 31,000 collectively in our secondary service areas.
Great. Thank you for that. All right. So we are, the objectives for this particular education session is to really kind of showcase where you can collaborate versus compete. And I think one of the things I think is so important for us to talk about first is that you are working on addressing your workforce challenges. And you would have to be living under a rock not to understand how challenging our workforce pipeline, how challenged we are where rural health is concerned. So as a part of your collaboration, you developed a teaching health center residency program. And so you're also doing this in partnership with White Mountains Community College. And so I would like very much to have you both kind of talk about a few minutes about that initiative, those 2 initiatives, and some of the how, because we say it's great to have these partnerships, but why did you do it and how did you do it? And a little bit about what you are, where you're at right now with this really important and impressive program.
Well, thanks, Michelle. We started because we realized we weren't going to recruit our way out of a physician shortage issue. We needed to grow our own. And so I think it was in the middle of COVID, I came to Mike with this crazy idea that we needed to stand up a teaching health center family medicine residency program. He didn't laugh me out of the room, took me seriously, and devoted a number of resources, staff time, and other things to help stand this up. This was some 4.5 years ago. We were fortunate enough to receive a planning and development grant from HRSA to stand up this program. We were accredited by the ACGME a couple of years ago, and we're looking to welcome our first class of residents in July of 2027. It's been a labor of love. It's an incredibly challenging thing to stand up, but something that's critically important, we think, to the future of our communities and to the future of our organizations.
Michael, what does that mean for you all with the hospital? I mean, because so often recruiting is such a competitive sport. I mean, everyone's looking for it's not just physicians, by the way.
Mhm.
It's advanced practice, health professionals, it's IT, it's you name it. So what does this mean for your organization and its future?
Well, Androscoggin Valley Hospital actually doesn't provide any primary care. So that's first and foremost. As we recognize, we depend as a specialty service hospital. We provide most of the specialty services to the region. We depend on the referral base that comes from Ken's organization. So any investment in growth in the primary care is going to serve us and the community as well. So we see this as a long-term investment. And you're right. We've been somewhat successful in recruiting existing providers, but growing our own, we knew was going to be the secret sauce to be able to, in perpetuity, graduate a number of primary care providers. So if we get off on as planned in 2027, starting in 2030, if we have 4 residents that we're graduating every year, that potentially, based on the data nationally, we could count on close to 2 primary care providers that stay in the region. And that feeds our pipeline as attrition comes along and providers leave the area or retire. That we need to keep continuing to build that pipeline for the foreseeable future, because all of the continuum of healthcare depends on it.
That's like a dream. I mean, that would be such a dream of any organization to have that, that level of assurance that you have 2. I mean, for most folks, they don't understand what 2 providers, means to a community, and it's significant. Okay, before we got a few minutes before we bring in our next 2 panelists, but I do want to talk about your collaboration that goes beyond workforce, and there's so much of it. But one of the things that stood out to me was the 2 of you came together and you started the Great Northwoods Community Foundation. And this gets right to the heart of community engagement where I am concerned. Talk about that program. I just think it's remarkable because the departure from like a hospital foundation, if you will. What do we need to know about that?
So that was actually quite serendipitous. Ken and I sitting down at a diner talking about how we were going to overcome an impasse with something else we were dealing with. We recognized that neither of us really had in our own organizations the directive, if you will. It wasn't part of our charter or our bylaws to say we're here to address social determinants of health. And we know that makes such a difference in terms of the overall wellness and quality of health and quality of life in our community. So instead, we jointly formed this organization that was the role for the foundation. And we defined a governance structure that it reports up to equally both boards of our respective organizations. We set an administrative structure up so that it's equally administered. And we both put in seed money to start to attract funding from other resources. And collaborating, we can truly move the needle. And that actually does draw more attention from other funders. And to date, we have not actually had to increase our annual seed money, and we've grown a lot in terms of what we can deliver to the community because we've attracted the attention of other funders. And I'll let Ken talk to some of the results.
Ken, because I know that the position that you're in, what Michael cannot do, you all do, as do health centers across this country, which is to identify unmet non-medical needs. And so who better than your team to understand truly the impact that this kind of funding can do? And I remember in the conversation that you guys were looking at purchasing air conditioners for senior population that didn't have them. So talk about what that means to your health professionals in your clinic and the impact, if you will, on the community as a result of this really strong initiative.
Yeah, I think it means a number of things. To the individuals who receive direct assistance, it means being able to stay out of the emergency room because of an exacerbation of COPD in a hot stretch. It means knowing that somebody has their back. I can't really overstate that. Um, Individuals understanding that there are people who are there to care for them, not only for their medical needs, but also to recognize that the other things that are important in life. So these funds have been used to pay for transportation, for
Mhm.
medication, for electric bills, for caregiver support, you name it. We've tried to be as responsive and person centered as we possibly can while tying it back to the individual's medical plan of care.
I bet you that makes a difference for outcomes, and I'd love to see that data. That is also the power of collaboration when you can. It's not just what you do on the front end; it's what you see it happening on the back end, just as you would for quality outcomes. Ken and Michael, you are not going anywhere. You're going to stay with us because just as we have to keep on time, so we make sure everyone has a chance to ask and answer questions as well. We're going to just ask you to stay with us, and I'm going to bring in our next two. And by the way, everybody, after this is done, you're going to make sure that we can connect you with everyone that you saw here today. Their case studies, as I still will be coming to you, so just sit tight for that. And in the meantime, I'm going to invite our next two panelists to the stage, and that is really introduced to me by somebody. I'll tell you first is Jim Pettinato and Terry Lacey, and they are joining us, both of them from Pennsylvania. And we are so glad that you are here with us today, Jim and Terry. I told you before that the reason why I found out about you was through the great Lisa Davis from the Pennsylvania Office of Rural Health. When she says you have to meet Jim and Terry, I believe her. And quite frankly, she's also tiny, but I'm scared of her because of, just the powerful voice that she has in rural health. So Jim and Terry, thank you so much for joining us.
Well, thank you very much. Yes, when Lisa asks you or tells you to do something, you do it. So yes, but pleasure to be here today, and glad to be part of this.
Well, Terry, let's start with you. Give us a snapshot of your organization, kind of the full name, because again, everyone heard it in the very beginning, but in case they forgot, full name, where you're located, and then Jim, let's have you follow up with the same.
Great. Thanks, Michelle, for hosting this. My name's Terry Lacey. I'm the CEO for Wayne Memorial Community Health Centers. We are located in northeastern Pennsylvania. We cover 4 counties, and we have 22 care sites that are spread out across the geography. We provide about 220,000 visits annually, and we have about 140 clinicians. In addition to maternity, we're going to talk about today, we're going to highlight that. So we have our women's health offices, we have adult primary care, pediatrics, dental care, behavioral health. We have integrated care model. Really, I'm very proud of. We have podiatry. We have a community-based veterans clinic, and we have 4 walk-in sites.
That is no small feat. And Jim, tell us about your organization. I mean, we've talked a few times, but I'm still trying to wrap my brain around how impressive your organization is and everything that you all do.
Well, thank you. We're a sole community provider hospital. We're the only hospital really in 2 counties, Wayne and Pike County. We have outreach in various counties where Terry and her team have offices. We really are responsible for the acute care needs for about 100 to 125,000 residents collectively in the area that we're responsible for, but it's very spread out. We have been responsible primarily for the specialty services and cardiology, pulmonology, nephrology, GI, general surgery, orthopedics, urology. Terry's team obviously has been on the primary care side, and really the synergy between the 2 groups it has been phenomenal in meeting the care needs, not only of our area, but actually of surrounding counties that are seeking care from our collaboration and partnership, because it's just unfortunately not readily available in areas that are immediately outside of. So we're a 92-bed acute care hospital, and a primary stroke center, and we also operate a cardiovascular lab, treating about 15 STEMIs every calendar quarter and about 500 total catheterizations a year. So a pretty busy
And
place.
all this in rural, and that's why I tell people, don't judge a book by its cover, because this stuff is really happening in places where we need it most. And what you're doing is, you are something I like to think about, is that you are kind of taking the distance out of excellence in medicine as a result of what you can do. Terry, I want to start with you, because your case study, and you sent me a really powerful video. I really want to make sure that we share that with our with our audience as well at some point in time. But you, like many across this country, are finding ways to manage a challenge around maternal health and about the maternity deserts that we have. Again, no secret in this country. So in your case study, we do call out that you were doing essential care, but in this particular area, can you talk to us a little bit about what that means to your community? Because you have a powerful story to tell. And I think there's a lot of people listening today that want to understand how you don't become one of those maternity deserts to the detriment of your community.
No, absolutely. As you mentioned, transportation is the biggest barrier. Distance to the closest hospital is a challenge, and the story of collaboration is really critical, because maternity care can't be done in a silo. It can't be done in isolation. It really has to be done in our model, between the federally qualified health center and the hospital. We're on track this year to deliver just over 500 babies, and our model is nurse midwife driven. So nurse midwives with OBGYN 24/7 backup for emergencies and for C-sections. And the first unique thing of our model is that all of the clinicians, nurse midwives, and the OBGYNs are employees of the federally qualified health center. So the benefit that brings is that all of the clinicians are therefore by FTCA, the Federal Tort Claims Act, Federal Practice Insurance, which comes at no cost to a federally qualified health center. So that's one financial advantage that it brings to the model, so that we can try to deliver care at the lowest possible cost. And what drives our outcomes? I talked about our geography. So we have 4 satellite offices spread out in our geography in order to address the needs of women's communities in which they reside. And because of that, we get about 88% of our women into care very early in the first trimester. And because of that engagement with the women in the communities early in their care, we only have 6% of our babies are born with low birth weight, and our C-section rate is 7%. And all that's really attributed to thorough intake and screening of patients by an RN case manager that really stays connected with those women throughout their pregnancy. And it's really, Michael brought up the social determinants of health. We screen for all the social determinants of health early in pregnancy, looking at employment and income and food and housing, education, literacy, insurance, in addition to behavioral health needs. And we've done a lot of work putting a psychiatrist and a social worker in our women's health, looking at the behavioral health needs of the women, and creating individualized birth plans with the mothers in preparation of the team at the hospital for the delivery of that baby, so that everybody's well aware of who's coming in. Now, every once in a while we do get a surprise, right? Somebody who is transitioning through the area, new to the community, shows up without any prenatal care and delivers a baby. We do have that too. That's the reality of we provide. But for the most part, those cases are few and far between. And I think it's that upfront preparation and screening, and where the whole team, both the outpatient team and the inpatient team, are familiar with the individuals that are coming to deliver, really helps with the great outcomes that we see.
Yeah, Jim, I think about you and I think about so many of the rural hospitals that I work with and that we all are familiar with where they don't have this program and they are showing up and they're delivering in an ambulance or in the ER with staff that only does a few of these a year. Talk to us a little bit before we move on about what it means to have this kind of robust center of excellence. I know there's, you know, accreditations for that, but really that's the way I see it where maternal health is concerned these days. What has that meant for you all?
Well, listen, it's the difference between having an OB program and not having one, which would leave this area with the true maternity desert, not just in 2 counties, but probably 3 because Terry's team extends out into Susquehanna County as well, which only has 2 critical access hospitals in it. So for us, it is the life breath, if you would, of the maternity program. We could never, as an acute hospital, provide an OB service without this partnership. And I think the secret sauce is the collaboration. It's the exchange of medical record information, sharing of the chart information. It's one thing to be able to, through interfaces, share chart information, but to sit down with the birthing team in the office and the hospital and identify patients that might be at high risk, that might need special attention, and have two-way conversation about it, that can't be accomplished through an interface or sharing of a medical record. It's the cooperation of the birth team, of the nurse midwives, the obstetricians, to say Susie Smith is going to need A, B, C, and D when she comes in. And I think being able to have that degree of collaboration really makes for an easy pathway. In some respects, that note might be posted in the emergency room in an appropriate place that when Susie comes in, this is what we need to do for her. It's really that, to me, is the secret sauce, the teamwork and the collaboration between the hospital and the office. And geographically, the office is across the street from the hospital. So we've also been able to capitalize on the fact that they're in close proximity, even during business hours, to be able to run over to the hospital, address a need, in the middle of the day. But then they do provide really great coverage for nighttime services as well.
Yeah, and it's not a matter of convenience just for convenience sake. It really makes a difference when someone is presenting and they are truly in a crisis. Before we move on to our next case study, there was one thing I want to make sure I talked about too. And Gina mentioned it a little bit in the very beginning. You know, we do have new challenges that communities are facing. I mean, we know in rural America, we have had these challenges for a long time. They are in some cases accelerating. And one of them is food security. And so one of the things that I really appreciated about your case study is that not just out of security, but for health, you all have this food as medicine or this food prescription program, and you are really targeting something really important and not just addressing the obvious, but touch on that for just a moment before we move on, if you wouldn't mind, either one of you.
Sure. We did the food prescription program. We did it pre-COVID. So we actually wound up in what was supposed to be a 3-year plan to change the dynamics in our food pantry system. And in changing those dynamics, we were looking to target a couple of populations, those with BMIs over 25, those with BMIs less than 18, those that have diagnoses of COPD, heart failure, diabetes, and we really just, through the collaboration with the FQHC, patients were identified who were at higher risk for readmission, for complication, for deterioration. We were able to get those folks enrolled in our food prescription program where they got fresh fruits and vegetables and proteins. We also brought down on how to properly prepare the food. So meeting with our dietitians, meeting with our hospital people, because a lot of times good food, healthy food doesn't always taste good unless you prepare it right. And really, this wasn't supposed to be a program that was going to just ongoing financial support. It was really supposed to change the livelihood, if you would, of their decision making, so that when they disenrolled from the program, they learned good habits. They learned how to prepare that food. So again, while it was a financial assistance for a period of time, it really helped just change the dynamics of what the food pantry services were. And we still go out and still do help some folks when they need that specialty prescription to be taught how to properly cook it, even potentially provide it. And the last piece I'll say about it, we didn't just take care of the patient. We took care of the family too, because that's indoctrinating the family into healthy eating habits. And it was easier for the person to remain compliant if everybody at the table was eating the same thing. So while we might have had 430 or 440 people enrolled, a little over 300 were actually patients. The other folks were people that were the support personnel. and family members there, so that hopefully behavior change would stick when we were done, supporting the program.
Yeah, congratulations on that. It's such a wonderful program, and in the case study, you'll see the actual numbers. Data helps, and the stories matter. Okay, so Jim, Terry, thank you. I'm going to have you stay on because our last two panelists, and then we're going to open up for a really great, lively conversation. So with that, I saved this case study because I have to say, if I may, it's kind of the OG, if you know the term, because this is not a case study that is not unknown to those of so many of you, because this was showcased in an early document. I can't remember exactly what year ago, but I know that Kurt Walbillig is going to join us right now, and he'll be able to tell us, as well as Chastity L. Dolbeck, and they join us from Cole Country Community Health Center and Sacagawea. Oh, you don't know how much sleep I left over that one, medical center from the great state of North Dakota. We are so happy to have you with us. Welcome.
Glad to be here.
Okay, so I said, you're kind of the OG. So I want you to, Kurt, start us off. In 2019, I just got it in front of me. Your story was featured in HRSA's Guide for Rural Health Collaboration and Coordination. So you've been at this for quite some time. Give us the backstory, because you are the CEO. You wear two hats, multiple hats, but you're CEO over both of them.
Yes, I'm one of those individuals that I am the CEO of both the Federal Qualified Health Center, Cole Country Community Health Center, and Sacagawea Medical Center, a critical access hospital. So the community health center has 4 clinics in 4 different communities: Beulah, Hazen, which is about 9 miles apart; Killdeer, which is about another 60 miles to the west; and Center, which is another about 35, 40 miles between us and Bismarck. As a critical access hospital, we service with the clinics over 4 counties. Cole Country Community Health Center, and I think total was right around 27,000 visits. We have a great program there with our mental health. We're in the school. We have a school impact program, both with nursing and behavioral health. We also have addiction counseling. That's where all of our primary care is focused, is right in the Federal Qualified Health Center. Those providers also provided for many, many years the hospitalist work and inpatient work and ER work for the critical access hospital. And believe it or not, this is my second stint around. Both Chastity and I were on the critical access side over 20 some years ago when I was the CEO of Sacagawea Medical Center. And at that time, it was a different environment. It was a competitive environment with the clinic. And spring forward, 20 some years, and we have a great collaboration environment, and to the point of evolving into hopefully in the near future a network, not only with us, but with our long-term care facility, Knife River Care Center.
Yeah, we were talking about that when you and I met last week, and I find that fascinating, because it's not a consolidation. One might think it's a consolidation. It's not. It's to expand your capabilities because you've expanded your capacity. And Chastity, I'm so glad to have you with us today, because you are coming at it. Obviously, there's clinical people on this panel and non-clinical people. I myself am not one, and I don't play one on any TV, but I want your perspective, because you have a lens that's really looking through improving community-based care coordination. And because we're talking about creating pathways for transformative rural partnerships, talk to us about some of the things that you've done in this space to really up the game in community care coordination, because I think there's a lot of wins there and a lot of lessons that could be gleaned for all of us.
Yes, thanks, Michelle, for having us be a part of this panel. When I think about where our team started a decade ago and where we are today, it's actually kind of exciting to see the outcomes that we've realized, and to hear from our patients on what a difference our community care coordination program really has made. We started with just one registered nurse, and today we have multi-organizational committees that really work together to improve care for our patients through various services. Some of those programs and services that we provide are health-related social needs assessments and connections to care through various community resources. remote patient monitoring, virtual care services. We have a patient family advisory council that works on improving care experiences through the eyes and the voices of our patients and their families. A community health worker that helps patients in their homes with resources, behavioral health care coordination, a social worker and a nurse that work together to improve outcomes for our patients, a zero suicide initiative led by ND Hopes that includes standardized suicide screening and safety planning for our patients, school nursing that connects patients and families back to primary care. And then I think our biggest win has been our transitions of care, where our committee works on transitioning care from the local critical access hospital at Secaucus Medical Center back to the federally qualified health center at Coal Country Community Health Center. We even include our local long-term care facilities and local public health units. And some of those improved outcomes that we realized have been a reduction in inpatient discharges from 177 to 120, and that's per 1,000 Medicare lives. That's pretty significant. Emergency department utilization decreases from 555 to 349 visits annually, and a decrease in 30-day readmission rates from 171 to 118. So we kind of look at, our collaborative care coordination, and we know we've got a lot of obstacles and challenges that we still deal with every day, but I think we really truly work at keeping the patient at the heart of everything that we do. One of the shared goals that we've been able to realize just this past month in May, the health center and the hospital work together twice a year to work on preventative screening measures. And we have an event called Spring into Detection. It's a breast cancer screening initiative. In one day, our hospital completed 45 mammograms and 113 mammograms in the month of May. So that's a big win that we really truly celebrate in trying to really improve breast cancer screening for our small communities.
Yeah, and it's not even October. So thank you for doing that in the summertime. And I think, we say it's Awareness Day every single day. Chastity, you told me last week when we talked, and then and Kurt in this case study, something that really stuck out to me because I am on a quest. Anyone who knows me, I don't want to see another single rural hospital or health clinic or any entity closed, not one more, because we've been talking about this for years. And, Chastity, you had said, like, we wouldn't be here if it were not for this relationship. And Kurt, you use a term that says that this collaboration is reversing vulnerability, because we're really focused on reversing out migration, but you talk about reversing vulnerability. Could you talk a little bit more about that?
Yes, when we look at each of our three facilities, we're all pretty small as separate individuals or corporations. And one of the things we do have is a tertiary center that is ready to gobble anybody up that is vulnerable. And one of the areas that when I came here to take a look at is how do we prevent that? Our board of directors in both Coal Country Community Health Center and Skakwe Medical Center and Knife River Care Center, number one goal is to stay independent. That doesn't mean to stay or not to be interdependent. And what we found out, I think through these relationships, is we are interdependent on each other. So how do we grow that network in order to make sure that we are as strong as we possibly can to stay independent and to serve our patients the way that we know our providers live here, our staff live here. These are our neighbors, these are our family members, and we believe we know how to take care of them the best way. So how do we set ourselves apart and not be a statistic or being gobbled up, and to be strong to be able to continue to be here in the future.
Yeah, thank you for that. Okay, we've got a lot of questions coming at us, so I'm going to ask Gina to join us back here so we can go ahead and have everyone chime in. And I've got one that I want to ask anyone who wants to share this. your thoughts on this. Right now, there's a lot of conversation about rural health transformation. We know there's a $50 billion fund set up for that. And with that, there's a lot of questions about how this will be used and so forth. And part of that is, using it for technology and using it for mobile health. How do each of your partnerships, if you will, see how you might be able to harness some of the power of those funds as you see it, and where might mobility and technology help not augment or replace, but to enhance what you're doing? Does anyone care to chime in on that one? Kurt?
I'll start. Believe it or not, between the three organizations that we have, between Knife River Care Center, Coal Country Community Health Center, and Skakwe Medical Center, we have over 400 different software that our shared IT department take care of. Out of those 400, we have over 140 of them that are exactly the same software, but 3 different licenses because we are 3 different entities. That sets us up to where we're vulnerable from a cybersecurity, sets us up from trying to maintain all the software. We have 3 separate server clusters in 3 different areas. So one of the things that we are looking at with the Rural Transformation Fund is, and believe it or not, Coal Country Community Health Center and Skakwe Medical Center are all on the same Community Connect Epic through a larger center, but they're separate. So we can see things that go back and forth, but in our critical access hospital, we do have Coal Country Clinic in there, and we provide the lab and radiology services. Our patients get to register twice because we're on 2 different epics. So part of this is, how do we get to one GL software, one UKG HR, because we're all on 3 UKG HRs, getting to get one epic so we can have better care coordination between that. And if we had one epic, we can actually interface point click care, which is the long-term care software, into that, which will help with coordination of care. And how do we reduce our vulnerability in terms of cybersecurity and service clusters? Our service clusters run probably about $180,000 a piece. We believe if we do this, we can get to one service cluster in a cloud base, which is right there, a huge savings. But at the end of the day, how do we make this seamless to the patient, but yet how do we meet, the 3 separate entities?
You just made I don't know, did anyone else get a headache listening to that IT scenario? Oh my gosh. All right. Here's another question for everybody, whoever would like to chime in. It has to do with community engagement. You are doing so many things for your community. And so often I find it to be, you could put it out there, but people don't understand it. Let's talk about community engagement in terms of how you're able to get community influencers and others behind you, your schools, your faith-based organizations, any manufacturers. If anyone could talk a little bit about how they've been coming alongside you and how you've been engaging them to understand the asset that you are to your community because of your partnership. Okay, Jim?
This is something it's a longitudinal process. We meet fairly regularly with our local school districts. We meet with our county government on a semi-annual basis. Really, it's just keeping them informed of what's going on in the healthcare system. We centered around a common challenge for us in our communities, such as behavioral health. So between the FQHC, the hospital, the county, the school system, we've come together to collaborate on projects together to address, for example, the adolescent behavioral health challenges, the adult behavioral health challenges. That years of collaboration with each other actually prompted the county to actually fund and stand up a crisis center in the county, recognizing what the stresses were for the hospital, what the stressors were for the community health center. So I think, one of the real things we're proud of, that it's not something that happens overnight, but it's something where you keep them engaged and keep them at the table and find some common ground, that no matter what individual issues might be, no one can argue that the topic on the table is something that is really facing the community, and that we all have a piece of it that we can maybe address. So it's really fostering those relationships. And the other thing we've done is keep our hands in a lot of the community groups, be it the chamber, be it workforce development, workforce alliance, whatever those community organizations are. Getting membership on those keeps the hospital and the healthcare system voice out there, so that people understand what the real challenges are, because I've found by and large people don't understand the challenges facing our healthcare systems. You got to meet these folks on their terms, on their ground, to communicate the message. When there's crisis, that's not the time to get there.
Yeah, Gina, what do you have to say?
Yeah, thank you so much. Love Jim's comments. I think many of us on this call are aware that federally qualified health centers are required to have a board of directors that are 51% patient majority, and with the remaining members of the board being representative for the most part of the community. And so I just want to call out the boards of directors of health centers from across this country, particularly in rural America, who are influencers in their community. And while it's not always the easiest relationship to manage, I'm sure our CEOs on the call have had varying experiences in that regard. It's still a great way to stay true to the community, our patient voice, community engagement. And so thinking about the education of our boards of directors, thinking about how to support their understanding of the very complex environment that they're advising on, but more importantly, leveraging their community connections to support the preservation and sustainment of healthcare and social services in the community.
That's a great point. And also, critical access hospitals, of course, are made up of boards of community members for the most part as well. I have a question about the maternal health programs. And it has to do with the fact that, we are losing another maternity program, rural hospital, which leaves 3 contiguous counties with maternity deserts. So where does the conversation start? I mean, we're hearing a lot about the need to develop like regional hubs and so forth. Jim and Terry, I wonder if you have any insight that you can provide if someone says, listen, I am not going to sleep until I figure out a solution for us to collaborate. Do you have any advice about where leaders in your position could at least start to have that conversation to determine what path there is forward? Because I don't want to hear there is no path. There has to be one, right? Where this is concerned.
Yeah, so the community health needs assessment that both the hospital and the federally qualified health centers are required to complete is a really great place for communities to come together to identify where can we collaborate. As far as maternity care, it really is this, it's a spoke and hub model, even in rural communities. It's those hubs that are out in the communities that are, screening women and getting them into the hospital, whether it's a large tertiary hospital or a small rural hospital. One of the things that we've done most recently is we've put ultrasound in all of those sites, sending ultrasound to a large tertiary facility being read by maternal fetal medicine doctors with, genetic counselors available to really identify those individuals at high risk that need to be delivered tertiary care. But, the rural communities and the rural hospitals are essential in providing care for maternity, for women and babies. 90% of the cases can be managed in the community in which they live. But it's identifying those high risk individuals that need to be referred to a tertiary care, and it's that screening that's so critical. And you can achieve positive outcomes in both models.
Thank you for that. I have another question. It has to do with workforce, and this is probably not going to be a surprise to anyone. I believe transformation begins from within, and we talk a lot about burnout and so forth. So I wonder if Ken, Michael, anyone, Kurt, you guys could talk about what you are doing to what makes your place a desirable place to work. Does your partnership help keep your culture strong? Kind of one voice, one team. I love the whole idea of high reliability and so forth. Talk about your culture and why your places are such a special place to work. And not only that, we talk about retention. So what's your retention factor as a result of your collaboration? If you could touch on that just a little bit.
Sure, I'll start and hand it over to Ken. Obviously, we start with retention because, frankly, we want to make sure that we reduce the number of vacancies we need to fill in the first place. And frankly, a lot of it goes to just making sure we're treating our employees well. Pay and competitive benefits is always, one of the things that people look at, but people want to be a part of a winning team. And when we have a collaborative nature with the rest of the healthcare continuum in the community, that just makes it feel much more like friends and neighbors taking care of friends and neighbors. And that's what people really want to be a part of. So we have actually had a great amount of success in attracting and retaining people who actually were from this area. We work together to identify opportunities to share staff wherever we can, including physicians, where we've co-hired physicians that we would not have either of us been able to successfully recruit in the first place. We've got a number of providers who are both family physicians and hospitalists, for example, and it keeps them, professionally satisfied, and it helps us to build that on that collaborative relationship to begin with. Ken, I don't know if you want to add anything.
Yeah, we do share a number of employees, including physicians. The hospital medical director is a family doc who's worked for us for many years. And we've been really, really fortunate to have a shared sense of purpose across both organizations. As Mike said, we're all caring for one another and one another's families. And that is an attractive proposition for many, many folks. I think we've also just really worked hard to communicate the mission of both organizations, and that we're here for the community and we're here for the patients that we serve. And that's where everything starts and that's where everything ends.
Thank you. Oh my gosh, we're getting really close to time, so I'm gonna put something out there as I always do. Anyone who follows me knows this. I'm gonna put out one last question to each of you. If you could just think about one word or two, in your mind, what is the power of collaboration? And with that, what do our listeners who have influenced themselves, what do they need to know about why it's so important for them to continue to make investments in the work that you're doing? Because you cannot do this alone. So that's a two-parter. I'm going to go around the room. I'm just going to call on you and see how ready you are. I'll apologize later. So, Kurt, I'm going to start with you. What is the power of collaboration, and what do those in influential positions need to know about investing in rural health?
I think two-part. I think number one is collaboration enhances the care of the patients that you serve. Without everybody being in a silo, that helps with that. Number two, sustainability. In this day and age of cutting reimbursement, 340B declining, how do you work together to be sustainable? Instead of having, three HR people, they're all individual, one leaves. Now you're done with no HR. How do you create a sense of a team and sustainability?
Awesome. Jim, what about you?
I'm going to say, the hallmark really is communication. You've got to maintain dialogue, even when times might be a little bit tough. The topics might be tough, and my second part of that is you have to find a way to say yes, even when the odds are against saying yes. There has to be some compromise. We independently and individually are not going to solve this problem, and I think if we keep the patients at the center of it, we can find a way to say yes and still keep all of us pretty solvent. And try to keep our community healthy. So they're my two.
Awesome. All right, Michael, what say you?
Sure. I think the first one is perspective. To make sure that we don't come at things just from a single lens. The power of collaboration to me is just understanding, gaining awareness of the downstream, upstream impact of any decision or action or direction we take. So that additional perspective just gains the value of the outcome of our decision making. And then second is alignment. Having a shared vision is so much more powerful. And when you bring really smart people to the table with that shared incentive, that shared vision for serving our patient wherever they are, it's a pretty powerful tool.
Chastity, I'm going to bop it up to you.
I'd say, collaboration for us is really our partnership. We cannot be successful out here as individual silos, and together we are better than the sum of our parts. So I just think that working together as our partners really is what's going to be successful for long-term sustainability.
Awesome. And Ken?
I'd echo the notion of us being better together. I think in rural areas that are resource limited, it's critical that we do that. And then I think a shared commitment to our communities, that this is why we're here. We're here to serve, and that we need to work with one another. Not only the individuals that are represented here, but all the other organizations that we've talked about today that make it possible for us to do this work.
Awesome. Terry?
I would say, through collaboration, we have to get to a win-win. And if we get to a win-win between the two organizations, the patients will end up winning in the end. And I would want the decision makers to know that without the rural health providers, there would be such disparity in care. There would be so many individuals that wouldn't seek care outside of their community, because many of them, they don't travel outside of their community. And so the impact of not having access to rural health care would be detrimental to so many of our patients.
Absolutely. And Gina, I'm going to save this last one for you because you are, yourself, I mean, the work that you do at the National Association of Community Health Centers is so important. So what is the power of collaboration in your mind? And for those who are listening, why is it so important to continue to make these investments?
Yeah, I want to thank this panel. They all took the words out of my mouth, but the power of collaboration is higher quality and smarter solutions than one brain could ever come up with. And then I would say for all of our resource investors out there, please continue to invest in this, in coordination and collaboration and convening, because that is the key to sustainable collaboration and partnership going forward.
Well said. I could not have said it better. And to all of you, I want to thank you. You have been so patient. This has been a year long. We finished writing the case studies almost exactly a year ago. I thank you so much. And I want to just say to everyone who's joined us today, over 410 people signed up, which tells me that there is a great interest in this topic. Just because rural health right now is very much in the headlines, it's not just a moment, it is a movement. I encourage you to continue to follow. Make sure you check your inbox because you're going to get a survey. And if we'll put a slide up here, you can take a QR code shot here of this slide, do the survey when it comes to your email. You could do it now as well. And then also, as I said, be watching for a link to those case studies. To everyone behind the scenes, to the National Association of Community Health Centers, to all the health centers and the rural health rural organizations, health organizations out there. I am so appreciative that you could join us. Be watching for this on YouTube. You can replay it and share it. And we encourage you to subscribe to the Rural Impact, and you will be staying up to date on all these and other matters that impact rural. I'm Michelle Rathman. It has been a thrill to be with you. We will see you again on a regular episode and another event just like this. Until then, make it the best day possible. Take really good care of yourself and to the best of your ability, all those around you. Thank you for joining us.